The dreaded Achilles tendon rupture. It oftentimes ends careers. Here in the US, when we look at the NFL, it can end about 33% of the careers. And even those who come back, they're not back to their same recurrent level of play. So we're going to hear from some of our experts. Dr. Nassif will be the moderator for this session, and it's all yours.
Thank you, Selene. It's great to be here. As you quite rightly said, Achilles is one of the most described injuries in history, and we're still here in 2022 debating about how to treat these injuries. So I'm very fortunate to have with me a wonderful faculty. This is how we're going to run this session. We'll start off with functional rehabilitation, whether as a treatment or improving surgery by Arfa and Arafa from Saudi Arabia. Open procedures for the acute Achilles tendon tears. Do we need to close the gap by Mohammed Mokhtar from Ain Shams in Egypt? And I'll be trying to go through percutaneous and endoscopic methods for the treatment of acute Achilles tendon ruptures. And we end off, of course, with Pierre Dehoux from Aspetar in Doha, Qatar, talking about performance concepts which might be guiding our treatment methods. And hopefully we'll have time for discussion and closure and some questions from the audience with all the speakers involved at the end of the session. So don't be shy and keep those questions coming in. So I'm going to unshare my screen now, and I call upon Dr. Arfan Arafa from Saudi Arabia to start with his presentation. Arfan, stage is yours.
Thank you, Selene and Nassif, for the preparation of this wonderful course about the Achilles tendon. I'm going to talk about the rule of functional rehab. You guys can see my screen, or yes? So the Achilles tendon, it's named after the ancient Greece mythological figure Achilles, because it was the only part of his body that was still vulnerable after his mother has dipped him into the river of Styx, supposed to be a river of power. So the Achilles tendon sees the highest load in the body, experiencing up to 10 times of the body weight during running, skipping, and jumping. Due to the unique blood supply with the watershed area at the 2 to 6 centimeter from the insertion, and this is the most common part of the injury and to the rupture, causing mid-substance Achilles tendon injury. Although the rupture, it's very common, as Selene outlined at the beginning. The treatment remains controversial about whether we treat this operatively or with the non-operative options. Rupture of the Achilles
Looks like he is frozen.
Arfan. Okay, yes, it looks like he's frozen.
You want to jump to the next one and then we'll come back to him?
Yes, I think that's a good option.
You can call him, Nassif. Do you have his number?
Arfan, you're back with us?
He's back.
Okay, all right. Welcome back.
The internet misconnected. So, if you have one of these comorbidities, diabetes, neuropathy, immunocompromised, or peripheral vascular disease, and then the guideline is to drift away from surgery to try to avoid the wound and the skin complication. But if you have a healthy patient without significant comorbidities, then you have both options. Then operative and operative management are both considered. The risk of the surgeries are clearly the wound complication, and then the downside of the operative management are remaining the high risk of re-rupture, elongation of the tendon, and possibly weaker tendon if compared to the operative management. Traditionally, if you look at the old textbook in orthopedic, and you will see the conservative management include casting the patient from the toes to the above knee with the knee in flexion and an ankle in plantar flexion, and to keep this cast for 8 weeks. And they describe the functional rehab as an aggressive rehab protocol, including immediate weight bearing. And this was in the 2006 from the textbook of American Orthopedic Foot and Ankle Surgery. And traditionally, they used to treat the Achilles tendon with the prolonged immobilization, and this was associated with the muscle atrophy, deep vein thrombosis, joint stiffness, in addition to the potential consequence of a re-rupture rate and weakness of the calf muscle. And in the last 10-15 years, the role of the functional rehab and functional bracing is becoming more popular. It's involved immediate and protected weight bearing in the brace to offload the Achilles tendon. And the concern about the safety of this is the risk of re-rupture and the weakness of the Achilles tendon. If you go back to the 2009 American Academy guidelines, they stated that recommend for or against the use of the functional bracing for a patient with Achilles tendon rupture treated with an operative management. In 2010, after the guideline, there was a multi-center randomized controlled trial, included 114 patients. They compared the surgical with accelerated rehab versus non-surgical with accelerated rehab. And then at 2 years follow-up, there was no difference in the outcome, including the re-rupture rate. In 2011, another randomized control multi-center trial, including a total of 80 patients with acute ruptures, were randomized to operative or non-operative technique. And there was no difference at 1 year, including the re-rupture rate. Mark Glazebrook is well known about researching on the Achilles tendon rupture and the functional rehab in 2012. He did the meta-analysis of the randomized controlled trials, including 10 studies included to this systematic review. If the functional rehab with an air range of motion was employed, the re-rupture rate were equal for surgical and non-surgical management with the p-value less than 0.05. If an early range of motion was not employed, the absolute risk of reduction of, achieved by surgery was 8.8. So there was benefit for surgical management if you have no facility to start early range of motion and functional rehabilitation in the patient with acute tendon rupture. And this is the plotted result showing the re-rupture rate in favor of the surgical operative management, but the p-value was not significant. The same applies for the strength in favor of the surgical management, but the p-value was non-significant. And the complication was a bit higher in the patient with the surgery, again with the p-value was insignificant. This is the recent systematic review by a group from Egypt and Ain Shams, and they did the 2020 another systematic review, including 9 studies were included, and 822 patients were enrolled into this systematic review. But they found the operative repair was found to significantly decrease the re-rupture rate, but with a higher risk of a wound complication. There was no statistically significant difference between the 2 groups in functional outcome scores or range of motion. But if you look deeper into these studies, the subgroups in their operative management, including both casting and the functional rehabilitation. So the conclusion of this study was in favor of the surgical management, but they pulled all the non-operative management of casting and functional rehab in one group. If you look at the rehab protocol, there are a couple of protocols. This is the most common one, the SMART protocol, and this is a study in 2009 looking at the SMART program for the acute tendon rupture. What they found, if you start this program, there is a low rate of re-rupture, satisfactory outcome, reduced rate of surgical intervention, and reduction in the healthcare cost. And the SMART protocol was published in 2015, is to apply the back slab, start no weight bearing for the patients when you see them in the emergency or the clinic. And then you assess in 2 weeks, and they do ultrasound. So all patients with the SMART protocol, they undergo ultrasound to assess the gap of the Achilles tendon ruptures. If the patient enrolled to be in operative management, these are the young patients less than 55, complete rupture, or if they have a gap of more than 1 centimeter. So these patients are in favor of the operative management. Otherwise, they enroll the patient to the non-operative conservative functional rehab. They start the immobilization. After 2 weeks of a cast, And then they walk with the walker boot until the week 8, and they start to restrict physiotherapy until the week 24. Other rehab protocol, they call the Leicester Achilles Management Protocol, the LAM protocol, and they have a prospective study on this protocol, and this protocol does not involve doing ultrasound. They keep the patient 8 weeks on a dynamic functional immediate weight bearing, whether with the cast or with the Vacupid at 30 degrees of equinus. They start gradual decrease of the plantar flexion every 2 weeks until week 6 or 8, depends on the surgeon and the patient. At week 12, assessment by physiotherapy for strengthening and the range of motion beyond neutral. The Achilles tendon rupture score was 75 out of 100 of an average 23-month post-injury. The advantage of this protocol does not involve ultrasound, and the re-rupture rate was a very low 2.2% with an outcome functional score of 76 over 100. One of the most recent rehab protocol is the Glazebrook-Robinger Achilles protocol for an operative treatment called the Gabont protocol. And this is a detailed protocol involving the protocol for the first 12 months. And as Dr. Selene said, the protocol and the Achilles tendon rupture will involve a very prolonged rehabilitation to recover from this injury. So from week 0 to 2, they apply a plaster cast with the ankle in a maximum passive plantar flexion with the non-weight bearing using 2 crutches. They start weight bearing at week 2 to 4. With the gradual increase of 25% of the body weight every 2 weeks to reach 100% at week 6. And they start active plantar and dorsiflexion at week 6 up to the neutral with inversion, eversion, ankle at the below neutral dorsiflexion. Between week 6 and 8, they start weight bearing as tolerated with the 100%. In the CAM boot walker without crutches, they started the resistance exercise, open and close kinetic chain, as well as functional activities to start with the resistance. Weight bearing exercise are not restricted, but they don't go beyond neutral degrees of dorsal flexion. Between 8 and 12 weeks, they start weaning off the CAM walker, and they start with the Achilles compression ankle brace to provide extra stability, and they return to the shoes with an insole and try to wean the insole as they have pain-free daily activities. Between week 12 and 16, they continue to progress on the range of motion, strengthening and proprioception, and they ensure the patient understand it's still a very weak tendon and still vulnerable for an injury, and they are not be able to return to sport at this point. They increase the dynamic weight exercise, including sport-specific training at a month after the injury. This will include skipping, jogging, and weight training. Between 6 and 9 months, they will return to normal sport activity that involve no contact or sprinting. And then at 12 months, they return to sport that involve running, jumping, or contact with the other team member. One of the most recent as well protocol is the UK STAR protocol. This is multi-center protocol, depends on a multi-center randomized trial, including 540 adult patients at 39 hospitals in the UK were randomized to assign to either plaster cast or functional brace for non-surgical treatment patients. So they have around 1,400 patients. Almost 1,000 patients were enrolled to a surgical management, and then 540 patients were enrolled to a non-operative management. And this group were randomized to either have a cast or a functional brace. So the plaster cast group had the below-knee plaster cast applied in a gravity equinus position, and the position was gradually changed until the foot was in a plantigrade at week 6, and the patient was permitted to start full weight bearing in the plaster cast at week 6, and the cast was removed at week 8. The other group is the functional brace group. They had a removable rigid walking boot. Initially, 2 solid heel wedges were inserted inside the brace to replicate the gravity equinus foot position. The participants were able to mobilize with the full weight bearing on their feet immediately after the fitting of the cam walker, and the brace was permitted some movement at the ankle joint up to the insole applied. The number of the wedges or the insole of the were reduced over 8 weeks until the foot reached the plantigrade at week 6 or 8, and the brace was removed at 8 weeks to start functional rehabilitation. So the conclusion of this protocol, the UK STAR protocol, the study found no evidence that the traditional plaster casting is superior to early weight bearing in a functional brace, as measured by the Achilles tendon rupture score. The study showed as well there is no evidence at the re-rupture rate between the two groups, and there was some favor of the economical health analysis toward the functional rehab, as there was no serial cast changing or a frequent follow-up to the clinic. So take-home message, the current available literature suggests that the treating of Achilles tendon mid-subset ruptures with the accelerated functional rehab, if you go with this line, the clinical outcome for an operative management and operative are similar. If you don't have facility for functional rehab, and if you don't have the patient are able to follow the rehab in your institution, and then advise them to go with the operative management. Thank you so much.
Thank you, Arfan. That was a wonderful talk. And now I think it's time to turn over to Mohammed Mukhtar. He's a professor of orthopedics, foot and ankle surgery from Ain Shams University in Cairo, Egypt, and he will talk to us about the open options. So, Mohammed.
Okay. Can you see the presentation, Dr.
Okay,
Nasser?
yes, Mohammed, everything is good and we can hear you and you can see your slides. So let's go.
Okay. I'd like first to thank Selene Parekh for his tremendous effort to accomplish this course. It's a really fantastic course. And I'd like to thank you, Dr. Nasser, for inviting me to give this talk. Thank you for organizing this session. And I'd like to thank the other speakers, especially Arfan, because he made the problem or the talk easier for me. He reviewed the literature about conservative and operative treatment in Achilles tendon. Now I will go to some practical points in management Achilles tendon ruptures. I have no conflict of interest regarding this talk. The options of an Achilles tendon rupture are either conservative, open or mini-open, percutaneous or endoscopic, that Dr. Nasser will probably talk about these topics. I prefer open or mini-open techniques in many cases. Why is this? Because as Dr. Arfan said, sometimes there is a gap even in plantar flexion. If you can see here, this photo is taken intraoperatively in 120 degrees plantar flexion, and still there is a gap between the two ends. So it's not always that the gap closes in plantar flexion. And this is the importance that Dr. Arfan mentioned in one study to do an ultrasound to make sure that the gap will close in plantar flexion. The problem is, even if this gap is filled with fibrous tissue and the tendon will look united, the Achilles tendon will be lengthened, and this is a cause of weakness and fatigue and dissatisfaction. The other important point is the debridement of the frayed ends, so to be sure that there is healthy ends on both sides of the tear, especially in middle-aged patient where the tendon may be with some degeneration in the substance of the tendon. So my protocol is open repair in any young active athlete to avoid the gap, and I think, in my opinion, that this may be the best option for young active athletes. However, there are many other colleagues doing different things with good results, but in my hand, I feel confident doing it open. Sometimes I do mini open technique. So like Dresden technique, I open mini incision, the aim is to see the sides of the rupture, debride it, and make good alignment, and then I can pass the sutures using any other technique to make the incision more small. And this is the typical case. This is the gap, even plantar flexion, and this is after repair of the tendon. This is the technique I usually do, and I did more than 100 cases in young active adults. My wound complications is about 5%. Re-rupture, 2 cases. Sural nerve symptoms, no, I had no sural nerve symptoms. And this is another concern that some devices that are used for percutaneous repair have more sural nerve entrapment and more sural nerve symptoms than open repair. Maybe Dr. Nassif will explain this to us in the next talk. So this is my usual technique to be more confident about the repair. If we do small incision, gentle soft tissue dissection, wound complications will not be very common, and all these 5% wound complications healed with dressing only without any need for plastic intervention. There are other situations where open repair is favored, at least in my opinion, because percutaneous or open or even conservative treatment will not be a good option. Like these cases of delayed presentation. I have patients who with the first presentation 2 to 4 weeks after injury. So the proximal end is retracted and with adhesions with the surroundings. So like in this case, we do release of the proximal fragment of the proximal end of the tear and try to close the gap. And at the end here, as you can see on the right side, we can do an end-to-end anastomosis even if the tear is 2 or 3 weeks after the injury. And Dr. Nassif knows that in Egypt, especially, we have a lot of these cases. So I had till now 15 patients with delayed presentation of 2 to 4 weeks. All of them were young adults, 26 to 42 years. So it's good to preserve the gastrocnemius function. So a tendon transfer sacrificing the gastrocnemius soleus complex in this age, in my opinion, is not very good. And it's impossible to do an end-to-end repair without an open technique. The FHL was needed in only 1 case. Direct repair was possible in 14 cases. However, wound complications were a little bit higher than primary repair. So 2 patients out of 15, about 12% of wound complications, but no plastic surgery was required as well. Another example where open repair is needed is the insertional rupture. This patient is a 48 years old female with long-standing insertional Achilles tendinopathy, and you can see the intratendinous calcification and the Hagland exostosis and the rupture here in the MRI, and the rupture is fresh. The tendon substance is not bad. There is no atrophy in the gastrocnemius soleus. I think in these cases also, percutaneous or minimally invasive techniques will not be able to solve the problems, and tendon transfer will just sacrifice the gastrocnemius soleus, which I think is not the best option. So in this case, as we can see here, we opened a small incision. We debrided the tendon from the intratendinous calcifications. As you can see here, we excised the Hagland exostosis to decrease the pressure on the tendon. And then you can see here, we are debriding the tendon and the intratendinous calcification. And then we remove all the bony prominence, and we attached again the tendon to the calcaneus using 2 anchors, like as you see here. And the wound is not very big. It's still a good technique with gentle soft tissue dissection. And as you can see here, the repair was done with a small incision. And this is the patient 2.5 months after surgery, before complete rehabilitation. So still not a good function, but she is still in the beginning of the rehabilitation. And you can see the wound is not a big issue, and with good healing of the wound. Another example is the re-rupture. In cases of re-rupture, you need to remove the previous stitches, debride the tendon, and assess the quality of the tendon and if it needs transfer. So this patient is a 34 years old, previous volleyball player with a re-rupture of the here Achilles tendon 4 weeks after the primary repair. So I think in percutaneous or mini-invasive in this case will be difficult, at least for me. So we did open repair and she needed FHL transfer. And this is the patient about 3 months after surgery with re-repair of the tendon and enhancement with an FHL transfer. So the take-home message that the perfect management of Achilles tendon rupture is still controversial. Each method has advantages and disadvantages, but open technique may be the technique of choice in special situations. And I'd like to listen to the opinion of other experts during the discussion. Thank you again.
Hey, Mohammed, we have a question.
Thank you, Dr.
When you do MIS technique, which way do you like your incision, transverse or longitudinal?
If I do longitudinal to be able to extend it if I need. But I usually do open incision, mini open incision, and do the Dresden technique, longitudinal incision, not a transverse incision.
Perfect, thank you.
Okay, so I will present now, share my screen. And okay, so is it showing everyone?
Yes.
Okay. So I will try and touch upon percutaneous and arthroscopic procedures. I am Nasaf Mohammed Nasaf, as we said. I'm a professor of orthopedic foot and ankle reconstructive surgery from Cairo, Egypt. Now, these are my disclosures, and hopefully they have no relevance to this particular talk. As we heard, it's the most common tendon rupture in the lower extremity. It's more common in males, fourth and fifth decades. And the goal, of course, is to restore the tendon integrity, its length, and to allow to a return of full pre-injury level of activity. The definitive treatment is still controversial, and authors have reported satisfactory results with conservative functional physio, open, and like Dr. Mohammed Mukhtar said, and maybe the minimally invasive techniques. Some authors consider that if surgical treatment options are going to be considered, perhaps the minimally invasive techniques are gaining more increased popularity. Now, these minimally invasive techniques have been a general term which have included arthroscopic and percutaneous ones. And the percutaneous has stemmed usually from the Ma and Griffith, which was described way back in 1977, to other techniques that have used K-wires, endoscopic assistance, and minimal incisions. One of these is, of course, the PARS instrumentation kit, which is a part of the percutaneous techniques. Now, Kakiuchi from Japan was one of the first who described the percutaneous, and he combined open with percutaneous methods, as the previous speakers have said, to allow better tendon opposition and decrease wound healing. Some authors, like Mohammed Mukhtar also just explained, they use ring forceps to guide their MIS techniques, and others would use a special instrumentation. And this was the whole idea, to reduce the wound complications, the infection, and the scar problems that have been more often than not associated with open surgery. And this was the precursor for the Achilles tendon, which was in 2002, and then later on the PARS device system, which was almost 8 years after that. And so doing the percutaneous techniques, like Selene just asked, you can use it longitudinal and transverse. If you're doing percutaneous, I would personally prefer the longitudinal incision, even though it has been originally described with a midline transverse incision, if you need to open it up more. And of course, it is along the lines of not with the force if you're doing plantar flexion and gradually increasing. So it might heal better. And of course, we all know the instrumentation system, how it goes through. It depends on passing pins, taking sutures, which are usually fiber wire number 2, and then you have 2 distal and proximal sutures. You end up with 3 sutures. You can tie them up. This is in the classical technique that was described, but you can also use certain passing lassos, like the banana lasso, and you can shuttle through the distal fragment of the Achilles, what's remnant of it, and then take these sutures and then tie them with swivel locks onto the calcaneal bone. And some investigators have even shifted to the use of fiber tape for added stability rather than the fiber wire. And if you go through literature now, you will find that the minimally invasive, the percutaneous techniques have certain outcomes that have been described to be equal, if not excelling, to the open and traditional conventional methods. And we have all seen our percutaneous patients, and we all know that they actually do quite well. And you can see the regainment of the musculotendinous junction, and they do have adequate function, perhaps even a little bit earlier than those that have passed through conservative methods. And what about the endoscopically assisted? Well, authors have described endoscopically assisted tendon rupture management to try and visualize actually the tendon apposition and at the same time decrease the wound healing problems. But the classically described ones have been very cumbersome, they require a high learning curve, and they're not very easily reproducible by many. And so our group decided to do the endoscopic flexor hallucis longus transfer, which up until that time was being utilized with great success for chronic Achilles tendon ruptures. And we decided to do that on a prospective case series with a minimum of 18 months of follow-up. And so this is just a quick video to show the position, the technique. We use standard posterolateral and posteromedial portals with standard instrumentation, endoscopic as described by Van Dyck. We temporarily lower the contralateral limb to allow a free, adequate working space for your endoscopy. We then proceed normal endoscopic posteriorly. We identify the FHL tendon. You try and release it completely, especially proximally, to allow for future adequate tendon excursion. And then when you're sure that you have unrestricted excursion of that FHL tendon with the ankle and big toe in maximum plantar flexion, the FHL can be gently grasped, pulled proximally, and transected behind the talus, approximately at the level of the tubercles. So in Louis section zone number 1, you can do this, of course, with a surgical blade or an arthroscopic scissors, obviously from medial to lateral to preserve your neurovascular bundle. And then you gently grasp that, take it out of the medial skin portal, whip stitch it in a normal standard fashion, and then measure its circumference. It's usually less than 7 millimeters in circumference. And then we direct our attention now to the calcaneus. We do a mild posterior calcaneoplasty to visualize the native Achilles insertion. Then we do a posterior skin stab for future drilling of the calcaneal bone tunnel as near as possible to the native insertion. And we perform this drilling from posterior superior to inferior central within the calcaneal bone. We drill usually a number 7 drill, as we said. And this drill is usually a blind ended tunnel. We have rarely needed more than 25 millimeters in length. So it's a 7 millimeter by 25 millimeter length. You can even make it open if you want to do more tension. And you proceed to pass the sutures, leading sutures from the transected FHL tendon graft onto a passing pin that is placed into the prepared calcaneal bony tunnel. And of course, you transfer that FHL into that bony tunnel. And the remaining is just through the guide pin, you put the interference screw. But we have to measure the tension. We do that by elevating the contralateral limb and tensioning the sutures, maintaining that tension in comparison to the other contralateral limb. And then we place in the interference screw, which is usually not less than 7, as we said, even 8, to give adequate fixation. And we can visualize it endoscopically to make sure it has been completely inserted. And then, of course, the interference pin is removed, and you can clinically assess arthroscopically, first of all, and apply a range of motion, and then, or endoscopically in this case. And you can also clinically assess the degree of tension and using your clinical tests and the Achilles tendon resting angles to compare with the contralateral side and make sure that you have an adequate repair. You're ended up with 3 small incisions, stab incisions, which you close off with number 20. And we start from post-operative neutral below knee cast for 2 weeks, non-weight bearing for the first week, partial weight bearing next week. And we're fairly aggressive. We move after 2 weeks to a walking boot. And because we have that internal strut, and we start with an aggressive physiotherapy, at least at 4 weeks. Now, we also tried this with professional soccer players in both in Egypt, where I practice, and in Argentina. And we published the results. This has been recently published in the FAI, Foot and Ankle International. And we were amazed at the amount of the return to training, the return to play in months. And these patients were followed up for at least 1.5 seasons. Actually, some had completed 3 seasons post-operative their endoscopic FHL transfer. And so this was an MRI for one of these patients. And you can see this is the preoperative showing the rupture. We only do these for mid-substance ruptures. And this is 1 week where we document the tunnel position and the degree of proximity of the FHL tendon. And this is at 18 months post-operative. And you can see there's a homogeneous continuity of the Achilles tendon, which we actually did not touch during the repair. And then we currently have a study under publication. It has been just recently accepted. The aim was to compare this endoscopic flexure hallucis to a percutaneous mini open repair. Our hypothesis that both these surgical approaches might be clinically and functionally comparable with each other. So our primary outcome measures was clinically the ATRS, the AO fast ankle Heinz foot, and the Tegner activity, and we have a follow-up of a minimum of 13 months. Our secondary outcome was the FHL dynamometry, the ankle plantar flexion power, and the Achilles tendon resting angle, pre-operatively, intraoperatively, and post-operatively at the follow-up visits. Our complications, yes, in the PARS group, we did have a sural nerve injury. We had 1 re-rupture in both groups, and what was amazing was the return to the same level of activity at 6 and especially at 9 months was statistically significant than the in the FHL group than the PARS group. So in total, we were left with 117 patients. The follow-up range, as we said, from 28 to 64, from 30 to 64 months. There was no statistically significant difference in complication rates, but what was statistically significant was that 55% of our patients were of a Tegner activity score of 7 or more. And at the end, 93 and 89.8% returned to the same level of activity. So in conclusion, both techniques might seem to provide satisfactory results and appear to be comparable to other methods of management. The FHL cases seem to fare much better earlier, especially at 9 months. And of course, we would require higher quality randomized controlled studies to further elaborate on this technique. Now, this is one of our Argentinian players, not Egyptian, so he's a more higher level. This is a first division, and you can see the patient, that burst of speed is very good for someone who has just had the season before an acute Achilles tear. These are our references, and thank you very much for your attention.
Thanks, Nassif. There's a question from the crowd that in the setting of a chronic Achilles tear where you have gapping, how do you manage that gap, and how do you manage the shortening that you've gotten on that proximal stump?
Okay, so I assume the question is related to the endoscopic FHL in a chronic Achilles tendon tear, right?
I'm not sure if it's specific to your endoscopic.
Well, if it is, the beauty of the Sorry, Selene, to interrupt you. The beauty of the FHL is we do not actually address the tear. We use the endoscopic FHL in chronic cases for gaps that are more than 5 centimeters. And this has been documented in literature. Now, when you transfer that FHL, it's a biological and biomechanical strut that actually allows for regeneration, especially in these neglected chronic patients who have lost their push-off. And so when you go back and look at them and MRI them or look at their functional results after you've done the endoscopic FHL, whether even open FHL transfer, you find that the gap has actually filled in, and it's because they have this biological strut that their takeoff and their Achilles push-off has been compensated actually. So this was the concept we transferred to the acute Achilles, that at first we used to put in a suture between the distal end and the proximal end with the FHL. And then we found that it didn't actually matter. And so we just left the gap, and this is why we immobilized them in neutral, because we have that biological strut inside. So, Peter, he's going to tell us how his performance concepts would be guiding treatment after all what we said. Peter, stage is yours.
Thank you, Nassif. Hello to all the friends, and honor for me to be within this eminent lineup. Thank you so much. I have a lot of questions on that talk of yours, Nassif, but we'll take that further. So much fun. And then we come to the principles around Achilles tendon ruptures, where we believe we can learn from performance. Because in the end, it's all about prevention, it's all about load management, it's all about technique adjustment for training for specific sports, and it's about injury recovery and reconditioning. So we believe that when we talk about Achilles tendon ruptures, over the years, we've been able to bring our athletes back. But if you look at the literature and our own data, it shows that we're still not able to bring the patients or the players back in a reasonable time. 6 to 8 months is just way too long for an injury. When we talk about performance in the athletic world, but on the other hand, all our techniques have improved, all our techniques have downsized regarding complications and so on. But in the end, we have to remain humble and say, although our results are pretty solid towards recovery, the timing towards that is not that much evolved with our technique improvements, our industry support improvements, and so on. So with that humble comment, we believe that maybe performance from sport-specific other areas could help us out to bridge the gap. I have no disclosure to this talk, and you all know now that the Achilles tendon is the strongest, the largest, the most powerful tendon in our human body. It's formed by the gastroc and the soleus, the function we are well aware of, and this powerful muscle group facilitates mainly sprinting, jumping, and climbing. Now, when we talk about Achilles tendon ruptures, when you look at the mechanism of injury, we're now working with the isokinetic group, and we have defined, and that's in press, so more to come on that. We've defined 3 specific mechanisms. So it's not just one mechanism, the classic one that you feel a snap, you look behind and nobody's there. It's more than that. And if you look at recent football, mainly European football, you see that, for example, in the game Belgium against Italy, there was a high-speed running between a defender and an attacker, and you could actually see the mechanism on how the Achilles ruptured in Spinazzola, the player from Italy. The high exposure of David Beckham, his injury has gone through the world, and you also have players 5 months like Witzel from Dortmund down. You have players that 5 months before a European Championship ruptured their Achilles, and then what to do. So it's all about stress and strain curves. On the left side, you have the physiological area where the fibers that are normally cranked go straight. Then you have the overuse, follow-up in evolution where the straightened fibers show microscopic failure. And then you come into the point of no return where there's a macroscopic failure and an eventual rupture. Now, this is just a training ground of the Qatar national football team. If you look at what happened, you see one of our defenders just doing what he does 100 times a day, running back, taking the ball, touching the ball, and going for it. And boom. And we had that twice now over the course of 11 months. And this is a player that has a bilateral Achilles tendon rupture. I showed you the image. So although we believe we know on the etiology, the predisposing factors and so on, there still is something not right there, where not only the internal and external variables count, but also genetic fibers. And when we look at our data, for example, on hamstrings, we see that MRI is not helpful in defining the return to play time. But if you look at Achilles tendon ruptures, we actually do, and I'd love to talk about this in the discussion to have your opinion on that, because we see that the MRI can actually show whether there's still some intratendinous tears or fluid or hypotrophic areas and so on. So more to come on that. Now, when we look at the paperwork, the literature, we've published recently with the group in BGSM paper, showing that when you talk about return to play in Achilles tendon ruptures in athletes, luckily, 96% of our players return to play within 7 to 9 months, and national team players like elite level players within 5 to 7 months. Now, that's the epidemiology of it. We also see that 18%, 1/8, of the players do not return to the same level within 2 seasons. The post-operative re-rupture risk is about 3% if the players get the chance to return to play after 6 months. and about 8% if the players return to play before 6 months postoperatively. And when you compare that with the re-rupture risk conservatively in our series, you see that it's between 10 and 14%. So if you let them play 6 months after the re-rupture risk after surgery is 3%, that is compared to conservative therapy is 10 to 14%. Now, I'm biased, we are all surgeons, but this is the data we have. And then we look at what has been discussed by Dr. Orfan, Dr. Mohammed, and Dr. Nasif as well, which is the watershed area. We all know that it's between 2 and 6 centimeters from the insertion, but strangely enough, or not, due to the different mechanisms of injuries, you have different presentations. You have the distal ones with the bone flake that you saw in Dr. Mohammed's case. You have the mid-substance tears that are very prone to the percutaneous and minimal invasive techniques. And then you have the musculotendinous junction, where probably conservative therapy is the preferred area of treatment. More to come on that. But then again, we come to the specifics of the sport and the specifics of the treatment. And here you have a national team player from a surrounding country that had Achilles tendinopathy, had steroid injection, and has a partial rupture of the anterior part with an intersubstance longitudinal tear. And then we come into a picture of what do we do. I think the FHL might be a very interesting tool there, but it all depends on what the effect is on the football player, and also if we could do it, for example, percutaneous, grab that piece and fix it back, which is what we did in this case. So etiology. We all know that males are more prone to it, and there's specific age groups. The history taking is mainly fatigue and 3 different types of mechanisms that we will talk about. The predisposing factors, the internal ones are the alignments. Varus ankles in the hindfoot have more predisposition. The climate can be an important external variable predisposing. And then we talk about the risk factors, the quinolones, the steroid injections, and so on. And the clinical exam, surgery, no surgery, and rehab has been discussed. I'm going to go forward on this one because we've just listened to the pros and cons of the techniques. And then we come into a paper that we published, which is for the moment the largest level 1 meta-analysis on the up-to-date situation for the moment, where we identified 586 studies and filtered them to 10 remaining RCTs, where about 522 patients were included. Now, that says that open Achilles tendon repair is associated with longer surgical time, higher risk, you can read with me, while MIS repair is associated with greater risk of sural nerve palsy. So the re-rupture rate and functional outcomes are mostly equivalent, and we found a minimal invasive to be safe and reliable in our meta-analysis. However, we still need to put in the right data to have the nice put out of the data, and that's where we're not yet there. Now, when we talk about performance, we need to understand what's going on. I've showed some pictures. You have the picture of Kobe Bryant, who had an Achilles tendon rupture, was treated percutaneously, then re-ruptured, one big massacre, high exposure in the NBA, and so on. So when we talk about Achilles tendon ruptures is one thing, but the performance, the return to play, the reconditioning is another factor. And we have to understand the sport-specific details of that. You see that it's quite common in tennis, in badminton, squash, basketball. But nowadays, I don't know where it is with you guys, but everybody's playing paddle here. Now, paddle is like the worst nightmare for Achilles tendons in my practice since the last 2 years. It's all paddle related. And that's what I want to understand. We work with football players, we work with other types, but it must be sport specific, and the mechanism of injury is key. And when you talk about performance, we have to look at these sports or other sports in order to understand how we're going to tackle that. And we had the chance to work with our performance guys here. This is gold medal, Olympic champion, French triple jumper that aims at his third attempt, and he does that. He does that 100 times a day. So what do other sports tell us? You see the Thompson test, negative. This is the rupture. So a complete explosion with retraction over the tendon. But on the other hand, this is what he does after 3 months. This is what he does after 5 months. So it's all about bringing the pieces together, as Dr. Orfan and Dr. Mohammed also said, bringing that together, but it's then the question of holding it and creating a reasonable progress in load management in order to facilitate that healing and get the athlete back. And then we come into the world of biomechanics, because maybe we can learn from that. And when you look at the best sprinters in the world, there's basically 3 things that they're doing. It's the start, it's the acceleration, and it's the maximum speed, the maximum velocity. And if you look at Asafa Powell, he can show, I mean, he's one of the few people that in the world runs so many times under the 10-second 100-meter sprint. And we can learn from that, because when you see how they do in their injury prevention, such an acceleration of explosive movement while keeping the Achilles tendon alive, this is where we maybe bridge the gap. Now, I'm not going to bother you with all the specifics on biomechanics itself, but basically there's 3 things on load management. The first 2 meters, you reach 50% of your maximum speed in the 100 meters, which is pretty impressive. After 5 steps, you reach 70%. And after 50 meters, you're at maximum speed. That's what the elite sprinters do. Now, then you come into the fact that everybody's different. And you can see here the characteristics. You have the force production, you have the block time, the first foot contact time, the second foot contact time, but you have different styles. The athlete on the left is straightforward. The athlete on the right puts external rotation. Now, why do they do that? Because it's like an ice skater that uses the friction on the ice to get faster. And everybody has a different technique, but within that load management, you have to find the right pace as a coach, as a biomechanical support to every athlete individual. So it's a bit more complicated than that. And that's where we in our lab use the force plates. We have 12 force plates where in one line particularly, we are able to measure not only the force, not only the alignment, but also the acceleration, the accumulation of power. And that's where we come up with, it's called ground reaction forces, where in the block, the first contact and the second contact, we get this colorful data. But what is really important is that we have to learn from that. How can the limb prepare in order to accumulate that much power and still keep the tendons intact? The rear leg has specifications, the front leg has specifications, and even the arms contribute to that balance between horizontal and vertical propulsion. And then from the start and the acceleration, we come to the maximum speed run. And also that can teach us a lot, because that's what eventually the athlete wants to achieve. And when we come at maximum speed running, the ground reaction forces help us a lot, because it's all about the balance between vertical and horizontal ground reaction forces that need to find that balance in order to come into the eventual leading performance. So I'm not gonna go too complex on it, but what do we see? We have to look at the ankle, we have to look at the ball of the foot, we have to look at the trunk inclination, we have to look at the knee, and we know that eventually the recovery is initiated by knee flexion and ankle takes over. I hope this was a bit interesting, because we believe that when you talk about performance and sports, you have the injury, but you also have the specifications of the expectations of the athlete. And even if it's an injury or a prevention of a previous injury that you don't want to have a re-rupture on, you have to look at what are the expectations, not only from the athlete, but from the surroundings, from the external and internal variables to take into account. And if you want to know more about it, you can always let us know. So great to join this lineup of wonderful friends, and looking forward to the discussion.
Peter, that's a fantastic talk. You know, all of us traditionally have focused on just the patient's ability to heal and their satisfaction. But I think what's more relevant is return to play. And even more relevant than that is what you talked about, performance, right? Because especially with the elite athletes, they don't care that they just get back. They need to get back to the level that they were pre-injury. And it doesn't only vary amongst sport, but it varies even amongst position within the sport, right? So a forward is much better, much different than a defenseman, right? In European football, in American football, our receivers are much different than our linemen. So I think understanding those nuances and the expectations of what that position in sport demand will then dictate how we can educate these athletes as their ability to return to play. And to me, this is a huge area of research that's just beginning to be scratched for a lot of the young surgeons or young healthcare providers who are watching this and listening. There's tremendous opportunity here. And one last final comment. I don't know so much about football. I think that you guys do. There are databases of fantasy football, fantasy soccer data. But what we showed here in the US, our research group showed that we can use all of these data metrics that are being collected for fantasy American football and fantasy basketball and use that to evaluate the performance metrics of when these guys return to play and how well they return to play.
Yeah.
So, Nasif, you're back. We've got 3 minutes, so I'll let you take over.
Okay, sorry about that. Okay, so this was an immense session, really. Pierre, can you just unshare for a minute? Orphan, I have a question for you quickly. Are there people or certain Achilles tendon injuries that you would, from the start, say, I am not going to treat these conservatively?
That's a good question, Nasif. So, for what we have at the institution, if we have facilities to do the strict rehab, and if we have a patient who is committed to do the rehab, and then we can go with non-operative management. But in case that the hospital is lacking a good physiotherapy or the patient is far away from the institution where he cannot come and comply with the non-operative management, and then we would offer surgery. And then, to be honest, this is what we see most of the time, either lacking the facility in the institution or it's lacking the commitment from the patient. This mostly the patient that we face on a daily basis. But if we talk frankly, if we have a patient with a wide gap, I would go with the surgery. And the other group are the patient who has a rupture and a background of Achilles tendinopathy. I believe this group will not do well with the conservative management, and I would go right away with the primary repair and differential transfer. So these two groups, with a gap of more than 10 millimeter on MRI or ultrasound, or a rupture in the background of Achilles tendinopathy, I would offer them the surgery right away.
Great. Mohammed Mukhtar, quick question for you. Not all of these. Are you with us, Mohammed? Have you any tips on soft tissue handling, and what would you do with the knots when you're doing the open surgery?
Okay, the gentle soft tissue handling is very important. The assistant shouldn't retract the skin far widely because this is not good for the skin. I think a rapid operation, short tourniquet time, and try to make the knots away from the skin or the skin incision. So either from the inner side or with good soft tissue coverage. It's very crucial.
Yes. Pierre, you mentioned, Mohammed mentioned in his talk that he had a delayed rupture, and he defined that in that case as a 3 to 4 week rupture. Would you still advocate a percutaneous repair at that time interval, 3 to 4 weeks?
And I'll give you 20 seconds to answer that because we got to wrap up.
Yeah.
That's an answer for my colleague.
All right.
Okay.
Well, that was under 20 seconds. So
that was under 20 seconds. Yes. I think there have been papers that have shown that you can still do the percutaneous. There's still mobility at 3 to 4 weeks if you decide to go that way. Okay, Selene, I do not want to overshoot our time.
No,
it's
fantastic job.
Session. Thank you.
I really appreciate all of your expertise, guys. This was phenomenal. And thanks for being part of it. We'll be back in a minute.
All right. Thank you, everyone.
Thank you.